Good afternoon to all of you on the East Coast, and good morning to you if you are on the West Coast. My name is Jose Leon. I am the Chief Medical Officer for the National Center for Health in Public Housing, a project of North American Management. I want to welcome you all and thank you for attending today's webinar, Supporting HIV Education through AIDS Education and Training Centers. This webinar is being recorded, and the resources, slides, and other materials will be emailed to you after the webinar has finished. At the end of the webinar, there will be a question and answer session, and you will be able to ask questions to the presenter. I would like to thank HRSA for make this webinar possible through the National Center for Health in Public Housing. As I mentioned, we are supported by, and the information and content or conclusion of this webinar are not construed as the official position or policy of HRSA or HHS or the U.S. government. The mission of the National Center for Health in Public Housing is to strengthen the capacity of federally funded public housing primary care health centers and other health centers grantees by providing training and technical assistance. Now, before we get started, I would like to review some HIV statistics. Around 50,000 people get infected with HIV each year. In 2010, the Centers for Disease Control reported that there were around 47,000, almost 48,000 new HIV infections in the United States. And about 1.2 million people in the United States were living with HIV at the end of 2012. That's the most recent year CDC has reported the incidence and prevalence of HIV. Now, in regards to race and ethnicity, Hispanics and African American are the populations that are greatly affected by this disease, and we have that the new HIV infections are basically in the LGBT and MSM population. We have some PHPC data. This is what public housing primary care health centers are reporting to the Health Resources and Services Administration. And in 2013, we have that 6,397 patients diagnosed with HIV, and these patients visited any of the PHPC health centers across the nation. Now, there is a new recommendation from HRSA, and beginning with year 2014, UDS added an additional data element to this table, first-time diagnosis of HIV. The number of patients first diagnosed with HIV between October 1st, 2013 through September 30th, 2014 are going to be reported. This new recommendation came in December 2014. That's the reason that the first-time diagnosis of HIV is grayed out. For the 2015 UDS report, then PHPC are going to start adding information about the new diagnosis of HIV. However, in 2014, PHPCs reported 24,342 patients with an HIV diagnosis, and they had around 28,000 visits. So we have around 28,000 visits reported by public housing primary care health centers. Now, in regards to occupational HIV transmission and prevention, as we know, occupational transmission of HIV in healthcare workers is extremely rare. CDC recommends the proper use of safety devices and barriers to prevent exposure to HIV in the healthcare setting. For workers who are exposed, CDC has developed recommendations to minimize the risk of developing HIV. And I believe that is something that Dr. Henry Pacheco is going to talk a little bit when he mentions his Now, in regards to occupational transmission, as of December 31st, 2013, 58 confirmed occupational transmission of HIV were reported by the CDC. Now, healthcare workers who are exposed to a needle stick involving HIV-infected blood at work have a 0.23% risk of becoming infected. In other words, 2.3 of every 1,000 such injuries, if untreated, will result in an HIV infection. Now, I would like to introduce our speaker, Dr. Henry Pacheco. He is the program director for the South Central AIDS Education and Training Center at Parkland Health and Hospital System in Dallas, Texas. Dr. Pacheco has many years of experience working in the development and management of public health programs with a particular focus on HIV/AIDS, chronic diseases, and community-based health. Dr. Pacheco served as director of the Center for Health Promotion at the National Council of La Raza and as a private consultant in various health research and training projects in Latin America with the Pan American Health Organization. He has also worked as a senior health specialist with a CDC and as the program director at the National Hispanic Council on Aging and HCOA. Dr. Pacheco was the program director for the Texas-Oklahoma AIDS Education and Training Center, one of the 11 national clinician training centers for HRSA's Ryan White program for 5 years. He returned to Washington, D.C. and worked in various national health projects for a 6-year period. This year, he was offered the opportunity to come back to Parkland as director of the newly established South Central AETC. Prior to his work in public health, Dr. Pacheco worked as a primary care physician in private practice in Maryland for over 12 years. He was born in Bolivia, received his medical degree in Spain, and has lived for many years in Dallas, Baltimore, and the Washington, D.C. metro area. With this introduction, then, I would like to turn this over to Dr. Pacheco. Good afternoon, sir.
All righty. Well, sorry about that. Once again, good afternoon, and thank you so much. As Dr. Leon mentioned, I'm the director of the Henry Pacheco is the director of South Central AETC, one of the new AETCs as part of the organization. Our central office here is based at Parkland Hospital, but we're a network of collaborating centers distributed in 5 state regions: Texas, Oklahoma, Arkansas, Louisiana, and New Mexico. It is my pleasure to present to you a brief overview of the AETCs and share with you some of the ways we can work with Ryan White providers, primary care providers, health centers, and of course, including federally qualified health centers. I also want to remind you that we are one of the 8 regional centers, and as such, the points of view and activities reflect that of our center and myself. There are other centers serving the nation, and many of them have done their work pretty much since the beginning of the epidemic. And of course, I do want to thank Dr. Jose Leon and North American management for making this presentation possible. Let me first describe the objectives. I hope to describe the AIDS Education Training Program, perhaps discuss some of the goals of the AETC program, and of course, most importantly, describe how primary care providers and other health professionals can benefit from the regional and national AETCs. So who are we and what do we do? Well, the AIDS Education Training Centers are really a national network of clinicians, educators, and trainers that have the expertise in the diagnosis, treatment, management of patients with HIV and related conditions. The AETC program has a long history. It was established in 1987 by the Department of Health and Human Services, and it is essentially managed by the Health Resources and Services Administration under the Ryan White program. So we are actually considered the professional training arm of the Ryan White HIV/AIDS program, and as I said, housed in HRSA. The mission of the AETCs is the mission is to improve the care of the Ryan White program is to improve the care and treatment of people living with HIV/AIDS through multidisciplinary education and training. And as I mentioned, we're exactly housed within the Ryan White program of HRSA. Let me briefly introduce you to a map, and later I will tell you a little bit more where they can be located. But as you can see, This shows the location of the 8 regional AETCs, and as you can see, it covers all the United States, including Puerto Rico and the USA Virgin Islands and the Pacific Islands. So every state of the nation is covered by an AETC, and so it's just up to you to reach out to your local AETC, to regional AETC, to start working with them. In addition, there are at least 3 main national which first of all support the work of the AETCs, but are also a very valuable support for HIV providers and HIV clinicians. One of them is really interesting. It's called the National Coordinating Resource Center, NCRC. This is and I will give you the location of these centers in the website. But this is a web-based HIV/AIDS education resource that supports the needs of the regional AETCs through coordination development of training materials, curriculum, and through the rapid dissemination of any late-breaking or new advances in the management of HIV and related conditions. This has a great deal of resources that are available to the general public. These are high-quality products written in state-of-the-art science and written by experts and clinicians that are currently practicing HIV care. There's also the next one would be the National Evaluation Center, provides leadership in the development of design and testing and dissemination of effective evaluation models of AETCs training across the nation. The center works with the regional AETC program to assess the impact of their training activities on provider behavior and clinical practice. In other words, they measure what we do and give us guidance on how we can do better. The National Clinician Consultation Center is a very important center, not just for the AETCs, but for all healthcare providers, regardless whether you're involved in HIV care or not. This is a very valuable resource, and as I said, I will tell you where you can find them. It's something that almost every physician in the nation should probably have in their emergency Rolodex. The National Clinician Coordination Center provides healthcare providers with a national resource to obtain timely and appropriate responses to clinical questions related to the treatment of persons with HIV infection and other possible healthcare exposure to HIV or bloodborne pathogens. So, for example, it has the HIV management service warm line. It's an 800 number where any healthcare provider, this is not for the general public, where healthcare provider clinician can call for questions about HIV, AIDS, including antiretroviral therapy, clinical manifestations, laboratory evaluations. It's a very good place to call if you're caught in a bind, you're in a rural clinic, you have an HIV patient, or somebody has been exposed, and you want to know quickly what you can do. You can call this center, and as I said, the phone numbers will be given more or less at the end of the talk. There's the post-exposure prophylaxis hotline, the PEP line. It's also an 800 number, and that is to be used by clinicians for questions about occupational exposure, needles, sticks, splashes, where there is a possibility of exposure to HIV or other serious bloodborne pathogens. Once again, you're in a clinic, somebody was taking out the trash, accidentally somebody dropped a syringe there, now you have a puncture. And so what do? This is a good place to call to be walked through the process of deciding whether whether this was a serious exposure and how to manage a potential exposure to HIV, or when there is a known exposure to HIV. There's also the perinatal HIV consultation and referral services for questions about the care of the HIV-infected mother and the indications and interpretations of the HIV tests that are done. And there are a few other centers that have been formed along with these centers. The Electronic Clinician Consultation Service, the Clinical Substance Abuse Consultation Center. It's a tremendous resource that every clinician should explore, and I will give you how to get to them easily, readily, and anytime. Well, what do the AETCs have to offer, the regional AETCs? In essence, we offer training, education, and technical assistance. Who is our main target? Healthcare professionals and healthcare organizations. And that is the folks who are either involved already in or are planning to be involved on prevention, diagnosis, treatment, and management of HIV diseases and related health conditions. This could include definitely, for example, hepatitis C virus. My little icon there doesn't show well, but of course, definitely HIV, STDs, substance abuse, HIV testing, linkage to care, and in general, all of this gamut of health conditions that are somehow associated with HIV. Just to give you an idea, in the year 2012-2013, the AETC provided more than 15,000 training events. These included didactic presentations, skill-building events, clinical trainings, group clinical consultations, individual consultations, and of course, technical assistance that's offered to clinics, hospitals, and health centers that are either becoming involved or are already involved in HIV care. We have, in that year, 2012-2013, for example, we have reached, as I said, in these 15,000 training events, we have reached over 150,000 trainees. Out of those, about 17% were physicians, about 33% nurses, dentists, and oral health providers were the rest, but over 40% were minority providers, and 73% were women. Minority or minority service providers are very important target population of clinicians, simply because, as you know, the epidemic is having a significant impact in these folks, in these populations. Who are the primary targets for training? And of course, they are, first of all, novice or low-volume providers. We're interested in these folks because we need to move them up the scale so they will be full-service, confident HIV providers. The problem is this is a very large country. There are excellent clinics in major metropolitan areas and many centers. However, there are many other communities, rural counties that are tremendously underserved because there's no or very few clinicians that have the knowledge, the expertise to manage HIV. Of course, another very important primary target for training are clinicians and health professionals that work at federal qualified health centers. Already a large number of federal qualified health centers are involved in the clinical management of HIV. They have been involved from the very beginning of the epidemic. But there's thousands of other clinics, including sites, that have not yet incorporated themselves in the provision of HIV services. And of course, we are here to help them make that transition as easy as possible and to provide them every support, not just in clinical knowledge, but also in organizational management and how to set up their clinics in order to serve people living with HIV. A very important target is also allied health professionals, medical case managers, social workers, and others. These folks are the glue that makes any health service work. They are the ones who are between the clinicians, the nurses, and the patients, and thus provided personalized service to the patients. They know their patients by name, they know their circumstances, they know their families, they know their living conditions. So they really help to help patients, and they bridge the gap between the very busy clinician and the needs of the patients, other needs, social support needs, in order to stay healthy and be able to manage this condition. An important target is also faculty of health professionals, faculty of medical schools, nursing, and other health professions. We need to get HIV integrated into the curriculum. Many medical students, nurses graduate with having very minimal exposure to HIV. We think that they should have greater HIV exposure, so when they get out, they are ready and willing and skilled to manage patients with HIV. And of course, not new, because many AETCs have already been working with these folks, but also community health workers and promotores. These professionals, paraprofessionals, in many ways provide a very important service in terms of outreach, prevention, and education in the community. They help to link the communities to the health services. They're particularly important in underserved populations, very much used among Latino populations because these promotoras are usually bilingual and they come from the communities where they are very much needed. The Minority AIDS Initiative, of course, has provided us additional funds, additional to the Ryan White HIV programs, to supplement the findings in order to build the capacity, to increase the capacity of minority-serving healthcare professionals. This is obviously because the epidemic is having a significant effect, as we know, on African American, Latino, and other minorities. And of course, with the Minority Initiative, also allows us to provide training, education, technical assistance to allied healthcare professionals and those serving racial and ethnic minorities, including, of course, clinic-based clinical care organizations. We're very grateful for the funding that we receive for Minority AIDS Initiative, and we put it to use in addition to, of course, all of our other services. So what are our goals? Our goals are essentially to increase the size and to strengthen the skills of the HIV clinical workforce. Later you will see why is it that there is a significant shortage of HIV clinical providers. There are many reasons for it, but we need to increase and strengthen the skills of these folks, of this group of healthcare providers that provide service to people with HIV. We also, of course, need to improve the outcomes along the HIV care continuum. I will go in a little bit more detail in what we mean as the HIV care continuum, but I just wanted to let you know that we are focusing on this and we're using this as a marker of how well we're doing and what are we doing and what area of the continuum do we need to concentrate in a given community, in a given city, in a given county. Our third goal is to reduce HIV incidence by improving the achievement and maintenance of viral suppression in people living with HIV. As you know, if we lower the viral load to undetectable levels, we significantly decrease the infectivity of these folks as they have unprotected sex with those who are HIV negative. So these are some of our these are the goals of the AETC. In addition, the work of the AETCs is in full alignment with the goals of the National HIV/AIDS Strategy. As you know, the National HIV/AIDS Strategy was first released in 2010, and it's a 5-year plan that details principles, priorities, and actions to guide our collective national response to the epidemic. As such, the AETC supports the goals of the National HIV/AIDS Strategy, which are to reduce new infection, increase access to care, and improve the healthcare outcomes of people living with HIV. And also the other goal is to reduce HIV-related health disparities. Later we'll explore a little bit more, and Dr. Leon already introduced us to the significant health disparities that we still see in the country. Lastly, the other goal is, of course, to coordinate a national response to the HIV epidemic. We should all work together, coordinate it, and use the best of our efforts to corral and finally defeat the epidemic. So we are very much working in alignment of the National HIV/AIDS Strategy. What are our how do we work? How do the regional AETCs conduct their work? We provide didactic presentations. Some of them can be self-study, interactive skill-building presentations, of course, to our target audiences that I mentioned before, our healthcare providers, clinicians, social workers, nurses, pharmacists, dentists, oral health professionals. We also offer clinical preceptorships in centers where you have HIV experts providing expert clinical care. And we are, of course, participating in and organized communities of practice. We offer clinical consultations to those clinicians that are working with us, working in the programs, those clinicians that have gone through through our process of longitudinal training, of didactic presentations, clinical preceptorships, they end up developing a relationship with an HIV expert in their localities, in their city, in their county, in their state, and these folks will be there ready for you to provide mentorship and clinical consultation. There's also coaching and technical assistance for organizational capacity. So not only are we involved in increasing knowledge and skills in the clinical arena, but we also want to build the organizational capacity of health centers to provide health services. And of course, all of these trainings and technical assistance are based on assessed local training needs, the needs of healthcare professionals and the needs of healthcare centers. So we work with professionals, with healthcare centers in identifying where are the gaps, where are the needs that they have, and we tailor, the AETC will tailor their trainings and technical assistance to the needs of these centers, so to be sure that this is a very personalized, very close relationship. We offer comprehensive packages of trainings and technical assistance that seeks to advance these providers towards a greater capacity to provide HIV clinical care. And of course, I do want to reiterate that the training and technical assistance is not limited to HIV, but also encompasses a wide range of associated diseases, and we are particularly focusing on, of course, hepatitis C, for which now there is a very good process to lead to actual cure. We also know there are a lot of folks who are co-infected with HIV and hepatitis C. We're, of course, very interested in the control of STDs, STIs. They are many times the door or the signal that these folks are not practicing safe sex and are exposing to diseases that can be an opening to being infected with HIV. Of course, we also deal with other diseases such as tuberculosis. As such, the AETC seek to create and support partnerships with healthcare organizations providing direct patient care at the local level, and particularly federally qualified health centers that are not providing HIV care. Why is that? Because federally qualified health centers serve thousands of people, particularly in communities that are medically underserved, particularly minority communities. So these are great centers that provide the services where HIV needs to be in their menu of clinical services that they provide. In addition, in this new cycle of funding for the AETCs, HRSA has introduced two innovative programs that I think that are very important, and we're very excited. We're just beginning with this. The goal of this two new projects, which is practice transformation, which is one of them, and the other one is interprofessional education project, the IPE project. The goal of both of these projects is, of course, to increase the size and capacity of the clinical workforce. That's the most important. And, of course, to improve the outcomes along the HIV care continuum. So we want more physicians, more centers there capable of providing quality care to people with HIV in the nation. Just a little brief information on what practice transformation is. In practice transformation, the AETCs will work with selected clinical practices to build their capacity to provide quality care. So all of the regional centers will have selected a group of FQHCs, Federal Qualified Health Centers, and a group of Ryan White HIV providers, and working along with them in collaboration with them through practice transformation, we seek to increase their capacity, to build their capacity to provide quality HIV care. We think this is an exciting program, a new program, and as a little map suggests, there's a lot of centers that we can work with, but the AETCs are there in every state and have the capacity to cover the whole region. The HIV through professional education program, as my graph indicates, is focused on providing team-based didactic and hands-on learning in HIV care and treatment in postgraduate setting. As you know, physicians, clinicians, physicians train with physicians, nurses train with nurses, case managers train with nurses. We want them to start training together and to develop, learn to work in teams, because when they get out in the real world, in their clinics, hopefully they will continue with this idea of practicing teams, because in all honesty, the best way to serve people living with HIV and people who have chronic diseases is to work in collaborative teams. So that's, if they study together, they should work together. So this is what we mean by these graphics. One is from NYU Dental. And if you see that picture on the right hand of my slide, that fellow with the scrubs and the khaki pants at the very end, that's me, if you believe that. In any case, next, well, why the AETCs? Why is there still the need to have an AIDS education and training center? Well, because we are beyond the HIV/AIDS of the 1990s. What are some of the challenges that we face? And of course, along with this, there are opportunities. First of all, we could say that currently there's a growing population of people living with HIV, and a little bit later on I will show why the growth, but it's a combination of good news and bad news. There's a growing population of people living with HIV simply because we've had tremendous success in the management of it, in the clinical management of HIV. In the 1990s, anybody who had HIV was faced with a deadly disease, and they essentially knew that their death was to come eventually, because we just did not have the knowledge, the armamentarium. But once we develop excellent medications, we learn more, now we can manage the disease so that these folks will live, they're pretty much close to their natural lives as long as they are under good care, under appropriate care. Unfortunately, other reason for the growing population living with HIV is that we still have, as Dr. Leon mentioned, close to 50,000 new infections every year, around 50,000, 47, 45, 50. A number that just has not changed in over a decade. So we're still having folks becoming infected with HIV, feeding this growing population of people living with HIV. The other current that justifies and calls for the need of the work of the AETCs is, of course, there's a persistent shortage of HIV providers. Many of the HIV providers now are reaching the age of retirement, so we need to get more young people interested in managing HIV, because we don't want folks who are infected with HIV in small towns, America, having to travel to large centers or having to drive 2 or 3 hours or so they can go to a major metropolitan center to an HIV, a Ryan White center. We want them to be treated in their locales, to stay in their locales, to keep their jobs and stay close to their families, to their friends, and get their HIV training from well-trained providers in their communities. So we need to increase the shortage of, address the shortage of HIV providers by getting more young people, more primary care providers interested in the management of HIV. And of course, we know that there's an unequal burden of HIV. If in the past HIV was significantly a burden for middle-class white folks, now it's shifting more and more towards the poor, medically underserved. African Americans are significantly affected by HIV, Latinos, and many other minorities. And there's also geographical locations in the United States where the epidemic is really implanted and needs to be rooted out, needs to be cleaned up, needs to be resolved. The other interesting thing is that we have to shift our paradigm from considering HIV an acute disease with an imminent death associated with it. Now HIV, under appropriate treatment, if someone with HIV is tested early and enters into clinical management with a clinician that is well trained in managing HIV, this person is going to live their natural life. So more and more, HIV is becoming a chronic disease. Infectious, nevertheless a chronic, not curable yet, but a disease that it is possible to live with and lead a reasonable, healthy life productive life, and, a happy life. And of course, we hopefully will see the possible end of AIDS. Hopefully, in a few more years, nobody will see AIDS, because as you know, AIDS is the ultimate, the complication. AIDS results from HIV that has not been properly treated, an HIV that has gotten out of hand, and now we have a syndrome that is so serious, so deadly that was the main reason for death a few decades back. And hopefully in the next few years, we just won't see anybody with AIDS. They may have HIV, but only as a chronic condition. This next map shows you the unequal burden of the epidemic and the challenges. Obviously, the darker brown shows where the prevalence of HIV is much higher, the prevalence over 100,000, and of course the lighter colors of brown or red means that there's lesser numbers. As you can see, of course, HIV is heavily concentrated in metropolitan areas: Los Angeles, Dallas, New York, Houston, Miami, Florida. That's where HIV is having a significant impact. But then HIV is also affecting many smaller communities, many rural counties, and the challenge there is that because these folks may not have access to expert clinicians because they are in isolated communities. So what we need to do is create an HIV workforce that will cover the needs of all of these folks that are everywhere in the nation. And we also have to focus on regions where the epidemic is having a tremendous impact, and that is, for example, as you can see in the map, in the southern states, and particularly affecting, African Americans and, Latinos. Just as a setting, although Dr. Leon already expressed this, as you can see, part of the unequal burden of the HIV epidemic is that if you look at, for example, African Americans, yet they only represent 12% of the population. So therefore, it's significantly disproportionate impact. Latinos is not as bad, but still 23% of those folks diagnosed with HIV are Latinos, and yet they only represent 17% of the population. So you can see that minorities are highly impacted with the epidemic, but anybody and everybody who is living with HIV needs to be taken care of and needs to be provided the care that they deserve. In terms of how people are acquiring the disease, there is a difference between males and females. As we use this, as you can see, for example, in this slide, for males, 82% of males acquire HIV through male-to-male sexual contact, which tells us that these are the folks that we need to focus on to protect them from becoming infected, because as we can see, they are most at risk. Another group that contributes significantly to HIV in males, although to less than, are of course injection drug users, but there's still folks getting infected heterosexually. These are folks who are still not aware of what's out there in terms of prevention. I'm going to soon mention that we have powerful weapons other than sex, using condoms. Now we have PrEP, and we'll go a little bit more into it. So we have the instruments, we have the tools, we can make a difference. Among women, the overwhelming reason for infection is still heterosexual contact. Women are much more vulnerable to acquiring HIV through sexual contact. The mechanics of sex makes them more exposed to viral particles than, let's say, men, but another significant percentage, 13%, of course, through injection drug use. This graph shows a little bit of the impact of the epidemic. I just want you to concentrate in a couple of things. First of all, as you can see, the number of people living with HIV is increasing to the point where now we have over 1.2 million people with HIV. But this is an interesting graph because it's a combination of good news and bad news, as I say. number of people living with HIV is increasing because we are science is keeping them healthy, and they're living longer. So in the past, these folks would have died premature deaths. They're living longer, and that's why the increase. But in addition to that, we have in the lower part of those blue dots, this represents the new infections. And unfortunately, despite all of our prevention efforts, that number still hovers around 50,000 new infections every year, and we just have not made a dent. So these are still folks that are feeding the epidemic. And it's interesting to know that out of those that are infected, almost 12% are unaware. They don't know they have infected. They haven't been tested, and so they're going around and perhaps spreading the disease, the epidemic, unknowingly, simply because they just don't know they have it. As you know, HIV, when you first contract it, there's a prodrome of, body aches, swollen nodes, nothing terribly dramatic, mind you, that, often gets confused by just having a bad cold, and then it just goes away and you're feeling perfectly fine, but viral particles are growing, destroying the immune system of the person infected, and this person, if this continues having unprotected sex, or continues exchanging blood through the works that many injection drugs uses, these folks are still infecting people in many cases unknowingly. As I said, it's estimated that 1 in 8 are unaware of being infected, and of course, unfortunately, there's still thousands of deaths secondary to AIDS, something that we're hoping to have none in coming years. Now, we have the tools, we have the weapons. We know how we can take care of HIV to the point where people will have extended lives. But the reality is that we have a lot of gaps. And these are the gaps. These gaps are where primary care providers, community clinics, federal qualified health centers can make a big difference. But what this graph goes to show is that, for example, we know that there's close to 1.2 million people infected with HIV, and yet only 80% of those are diagnosed. Furthermore, of these folks who are infected, only 62% are linked to care. So if you can see that big gap, you have a very large percentage of people who are infected. They know it, but they're just not linked to care. They're not benefiting from having their HIV managed clinically, and they're out there, with further destruction of their immune system. And of course, retaining care drops even more. And even those that are in clinical care, a small percentage are on antiretroviral medications, which are really the ones who are going to do the clinical control and keep it in check, the growth of the virus in the body. And the ideal situation, the ideal position of having suppression of viral load or to negligible levels, we're only reaching about 28% naturally. Now, every county, every city, every community is being asked to do this type of analysis and to know where they are. This is a national, but in every community, New York and Dallas, by state, by county, you get a different range. Some are doing better than others. Some are, they have more people linked to care. Some have more people with the suppressed viral loads. But these gaps is where clinicians can make a difference. Not just clinicians, but also, case managers, nurses, those who link people to care, those that help to retain people to care, the outreach workers, the better training of clinicians to be sure that their patients are on antiretroviral therapy should increase this from 36% to 100% of those that are already engaged in care. So this is the challenge, and this is where we want you, the primary care provider, the case manager, the nurse, the community health worker to become involved. This next slide is pretty much works in conjunction with the previous one, but it seeks to show that there is a continuum of care. The continuum of care ranges all the way from those not in care to those fully engaged. And of course, from one extreme are those that are unaware of their HIV status, not tested, or never received results, continues to the other extreme, the best situation, which are fully engaged in healthcare, of course, with their viral load reduced. People don't necessarily go in a stepwise manner. Sometimes they are in medical care, but they drop out and they go back into this continuum. So the idea is to get everybody to be involved, the healthcare providers to be involved, and move people forward to the extreme right of this spectrum, where people are fully engaged and are receiving treatment and are benefiting from treatment. So in these folks, HIV will be just another chronic disease, maybe like a diabetes, something that they have to manage daily, but if well controlled, they can lead on their a nice, long, lengthy, productive life. Success is really within our reach. There is early detection through universal testing at every opportunity. Every American should be tested through CDC guidelines. At least everyone 13 years or older should, up to the age of 64, should receive an HIV test regardless. Those who are tested should be linked to care. It's not enough to give them the results, say, okay, you're HIV positive, go and find a physician. Anybody who does HIV testing should have a strategy to link those folks immediately to care. It doesn't do any good for them to know, well, that sounds good, because now they know they probably will be careful, but they need to be in care. And of course, once they are in care, appropriate HIV care treatment can suppress viral load. The AETCs are there. The AETCs are expert clinicians that have hundreds of HIV patients that are willing to train, educate, collaborate with those clinicians that may have a lesser experience with HIV or may not be providing HIV, to become, experts in providing appropriate HIV treatment so they can suppress the viral load, so these folks can live, extend their lives, live their natural life expectancy, and of course have quality of life. And of course, obviously, reducing transmissibility, which of course reduces their chances of passing this disease, of being contagious to others. And we also, in the past few years, we have a very potent weapon for people who are not infected but are at risk. Those discordant couples where one of them has HIV, the other one doesn't, has been tested, doesn't. There is what we call post-exposure prophylaxis, which is a daily medication that is prescribed that reduces the chances of acquiring HIV by up to 94% or more. And that is something, it's a new weapon. So with all of these strategies and many others, we can really corral the epidemic and reduce it in numbers, reduce transmissibility, and increase the life of those infected with HIV. In essence, the purpose of this, the importance of this presentation is our invitation, the invitation of all of the AETC, the regional, the national, to you, to the clinicians, be it physicians, nurse practitioners, physician assistants, community health workers, case managers, to join the AETCs, call them up, join them in supporting the goals of and the vision of the National HIV/AIDS strategy. In essence, we want to become a place where new HIV infections are rare. And when they do occur, that every person, regardless of their age, gender, race, ethnicity, or sexual orientation, or gender identity, or socioeconomic circumstance, will have unrestricted access to high quality, life-extending care. And that along with this, they're free from stigma and discrimination. Essentially, the ideal is that anyone can step into a clinic, and in that room there will be people with diabetes, with hypertension, with nosebleeds, and so he or she will be just the next patient, because the primary care provider, has the know-how to manage a chronic disease like HIV, like they manage diabetes, like they manage cardiovascular diseases. As any primary care provider knows, there's a point at which you need consultation with an expert. Well, develop a relationship with a local expert to get you out of, those situations where you feel that you need the intervention of an expert. clinicians are used to that. They're used to working in consultation, collaboration with experts. But I just want to show you this last slide. This, the entry point to all of the AETCs, the regional AETCs serving every community is this. You visit AEDCATC.org. It's right there on top of the slide. And you click on that, and that opens the door to all of the world of the AETC. You can, this map, these colorful maps are clickable. So if you live in New Mexico, you click that yellow where South Central is, and then they will tell you who the AETC is in New Mexico. You give them a call, you tell them what kinds of trainings you need. And as you know, we're funded by the federal government. So there's either no charge or very minimal charge for these menu of trainings and technical assistance. Likewise, if you live in any place, you live in California, you live in Nevada, you live in the upper states, in Washington, Oregon, you have the Frontier ATC, you live in New England, you live in Puerto Rico, the Pacific Alliance, Hawaii, there you have the ATCs. And once again, I want to emphasize that whether you're involved or not, if you're a clinician, particularly working in an isolated small hospital, you really should become acquainted with a clinician consultation center in case you have that patient that steps in that may have been exposed to HIV. You have a very short window of 48, 72 hours to act and make a decision. These folks can help you. These are trained folks, clinician expert, practicing clinicians who will walk you through the possibilities so that you can offer that person who has been exposed to HIV, that you can offer them the best coverage to seek and assure that they don't acquire HIV. So this is an important site. It tells you, gives you a resource library. It tells you a calendar where trainings are taking place. It puts you in contact with not just your regional headquarters, but those centers that are working in each community. For example, in Texas, we have over 5 centers working with us. They are there. You can reach them. In other states, there might just be one central office, but they know who's working in what community. So this is a very valuable slide. With that, I'd like to end my presentation and perhaps leave it for some questions.
Thank you, Dr. Pacheco, for this informative presentation. Thank you very much. And we need subject matter experts like you to keep us abreast on topics like the one that you have presented. Right now, we are going to start the Q&A session. If you would like to ask a question to Dr. Pacheco, please submit it through the question box on your control panel. Or if you are dialed in through your phone and would like to verbally ask Dr. Pacheco a question, use the raise hand icon on your control panel and your line will be unmuted. And we have one question, Dr. Pacheco. The first question says, does AETC in general provide video consultations such as telemedicine?
Well, I'm very happy we have this question because I failed to highlight a very important program that is part of the AETCs. We're fortunate to have them in our family because they are based in New Mexico. So, for example, that New Mexico has an ECHO project, which is at the service of the South Central ATC, but it also serves the whole nation. The ECHO project, for example, is a clinician training, online clinician training that can actually train clinicians longitudinally. It's an interactive, continuous relationship. But in addition to that, almost every ATC have videos, have webinars, have resources where you can actually get. If you go to that site that I mentioned, the site where I have the map, and you click on them and you get to the directory, you will see that there's a large library of PowerPoints, webinars, and also every AETC has live programs. So yes, we do offer that, and keep in mind the ECHO program from the University of New Mexico is a very important tool for the training of clinicians.
Great. Thank you, sir. Thank you for that information. Now, there is another question in the queue. Someone is asking, how can I get clinical or practical updates in HIV pre-exposure and post-exposure prophylaxis from AETC?
Well, first of all, one of the most important things to remember is what I mentioned. If you go to that map, you go to the Clinician Consultation Center, right? And they can offer you. They have a post-exposure prophylaxis hotline where they can. I'm sorry. It was a pre-exposure or post-exposure.
It says both, and specifically, this person is looking for updates in HIV pre and post-exposure prophylaxis.
Okay. Well, first of all, if it's in terms of updates and guidelines, wherever you're located, whatever city or state you're located, you can just click on that map and get in touch with the AETC and ask them to send you the most current clinical guidelines on post-exposure prophylaxis, on pre-exposure prophylaxis. We get that request all the time. So you can get just the guidelines, right? Or if you wish to schedule a training, they can probably offer a training. So any of your regional AETCs should be able to send you an electronic or a paper copy of the latest guidelines, and furthermore, show you where you can then later keep up to date with where the guidelines are. But in addition to that, I do want to mention that nationally, the Clinician Consultation Center, if you click on their icon, you will